Okay, hi everyone. Thank you for joining us today. Today's tutorial is on approaching headaches by Vinay. Yeah, just a couple of rules. If you're watching on the Zoom, any questions that are relevant to what you're covering in the moment, just pop them into the chat. Any questions that can wait till the end, pop them into the Q&A. If you're watching on the Facebook live stream, just comment your questions and we'll make sure that Vinay gets them and he will address them when appropriate. That's all from me, and I'll hand over to Vinay now. Thank you.
Cool, thanks, Erin. So today I'm going to be teaching you about headaches. It's going to be primarily for students in their clinical years, so third year or first clinical year or final year. And it's going to be a pretty comprehensive review on different types of headaches and how to take a headache history. Just a bit of a warning, it might take more than an hour. So just a bit of a warning for that. Right, so let's crack on. So in terms of the outline for this presentation, I'm going to be going through two different types of headaches. We divide headaches into secondary causes of headache and primary causes of headache. Secondary causes being the more serious stuff, but slightly rarer. Primary causes being the more common but chronic stuff. And I want you throughout this talk to basically be able to formulate a headache history. And when you do come across a patient who has a headache, you can rely on the classic Socrates mnemonic very well. But if you have these extra sort of questions at the back of your head, this makes sure that you're including or excluding important differential diagnoses that you don't want to miss out on. So, throughout the whole presentation, have in the corner of your piece of paper some questions that you might want to additionally ask, as well as the classic Socrates questions. So let's talk about secondary headaches. Secondary headaches are the most dangerous causes of headaches. They have the sort of higher morbidity and mortality compared to primary headaches. And so they're the ones that are the ones where you have your red flags. So in terms of the causes of secondary headaches, we have infection. We're going to be talking about meningitis. Bleeds in the brain. And we're going to be talking about subarachnoid hemorrhages. A raise in the intracranial pressure. Inflammatory conditions, which can cause headaches. Eye conditions, which can cause secondary headaches. Hypothyroidism and trauma. And the last two, I'm not really going to go into that much detail, but always keep at the back of your mind, if you have a patient with a headache, always keep hypothyroidism and trauma at the back of your mind when taking a history. But the other five we are going to go through, and I've kept them in the corner as a little reminder as to your five main causes of secondary headache. So let's go for the first one, infection. And the main infectious cause of headache that you need to know about is meningitis. Meningitis is infection of the meninges. And the main causative agent for this is Neisseria meningitidis. There are other causes, but that's the most common cause of meningitis. And clinically, we see this in patients through the triad of headache, obviously, because we're talking about headaches, neck stiffness, and fever. So already you're starting to think about how to formulate a headache history. Obviously, you ask about headache and ask them to describe the headache, but you also need to additionally ask about neck stiffness and fever. A few things that I've written down: Koenig sign and Brudzinski sign. This is something that medical schools like to teach you about, but is very rarely practiced clinically. You might want to look them up. There are ways of basically eliciting irritation of the meninges as proof that there might be meningitis. Other symptoms you would like to ask about to confirm or exclude meningitis are Rigor's photophobia, so that's when you don't like harsh light, so you stay away from the light, vomiting, and rashes. And I go into rashes because I'm going to talk a little bit about an aside about meningococcal septicemia. Meningococcal septicemia and meningitis are not the same thing. It's one of those things that people get confused about quite a lot. This particular rash, which is the non-blanching rash, that is a medical emergency. If you see that rash, the first thing you think of is meningococcal septicemia. The difference between meningitis and meningococcal septicemia is that meningitis is simply an infection of the meninges. Meningococcal septicemia is infection of the blood by the bacteria Neisseria meningitidis. There are two separate conditions. So if you see this rash, you suspect this meningococcal septicemia, you ask about these sorts of symptoms: fever, vomiting, lethargy, muscle ache. You do a sepsis 6 and you administer antibiotics and call for senior help. This is just a bit of a side, but I always think it's important to delineate the difference between meningitis and meningococcal septicemia. This is a separate emergency case. Okay, back to meningitis. So meningitis, infection of the meninges. So we've asked about these sorts of symptoms. There are other causes of meningitis for which you'd, in order to find out the causative agent causing this infection, you would like to do a lumbar puncture. But often in MCQs, there might be some clues in the clinical vignette which might tell you otherwise as to what kind of bacteria or virus is causing this. So these are just some examples. If in the history of headache, neck stiffness and fever, they also might have a previous history of a skull fracture, ear disease or occult neurological disorder like spina bifida, you're more likely to think that this is meningitis, like infection of meninges, caused by a pneumococcus. They might in the vignette say that the patient is immunocompromised, for example, by HIV. And if the patient is immunocompromised, the causative agent for meningitis is more likely to be opportunistic infections, such as fungal infections like Cryptococcus. And the way you diagnose a cryptococcal meningitis is through India ink staining. It's a black ink that's used. If in the vignette it says they've been traveling, you might want to think of malarial cause. And if they've been swimming in polluted waters, or if their occupation is in polluted waters, you might want to think of leptospirosis or Weil's disease as a cause of meningitis. But in general, these are the rarer causes of meningitis. The main thing that you want to think about is Neisseria meningitidis. I hope that's clear. We're still talking about meningitis here. And a really, really common question that comes up in MCQs is, here are the findings of the lumbar puncture. What is the cause of meningitis? What is the pathogen causing it? So we're going to go through some lumbar puncture findings, and it's going to help us diagnose what's causing this meningitis. So the first one, the most common, bacterial meningitis. And the way you're able to tell this is if you have a look at the cellular infiltration of the CSF, the cerebrospinal fluid, it will be infiltrated with cells called polymorphs. As well as this, the glucose concentration in the, are there different causative pathogens of meningitis based on patient age? Yeah, so there are, in neonates, it's slightly different. I can't remember exactly. You might want to look that up. So in bacteria, polymorphs infiltrate the cerebrospinal fluid. It's often described as pus-filled, and the glucose will be low. And the way to remember that is that bacteria love sugar, so they're going to be eating all the sugar, so the glucose levels are going to be really low. Viral meningitis. Viral meningitis is generally rarer than bacterial meningitis, not because there's less prevalence of it, but because it's less picked up. The symptoms of viral meningitis don't tend to be as severe as bacterial meningitis, so they don't tend to present to hospital as much. However, in the lumbar puncture findings, the infiltration of the CSF will be lymphocytic, so lymphocytes will be infiltrating the CSF. The description will be clear, and the glucose level will be normal. Viruses don't love sugar, remember that. Specific to, there's a specific bacteria which has a slightly different description, which is TB. So TB, the bacteria TB is often described as causing a turbid sort of look to the CSF, but they're also infiltrated with polymorphs. And fungal meningitis, you normally the CSF is clear, but there is a low glucose and there's lymphocytic infiltration. So the way in which you differentiate viral versus fungal meningitis is that the glucose is low when fungus infects. So viruses hate sugar, fungi love sugar, so do bacteria. So that's just a way of trying to remember how to diagnose using the LP findings. And like I said before, fungal causes of meningitis are much more common in immunocompromised patients, so patients with HIV, for example. Okay, that's everything you need to know about an infective cause of secondary headache. So that's everything you need to know about meningitis. We're going to be talking about bleeds, and I'm going to be talking about subarachnoid hemorrhage. And the main clue for subarachnoid hemorrhage is that the patient will often say it's the worst headache I've ever had. They tend to be slightly older, and they will have a sudden severe headache, also known as a thunderclap headache, that peaks at around 1 minute. It happens just like that. And the classical description is that they feel as though they've been hit in the back of the head with a cricket bat. And this causes a bleed in the subarachnoid space between the pia mater and the arachnoid mater. Other features apart from headache are neck stiffness, acute confusion, and neurological signs. So they might have a slightly lower GCS score, but they also might share some of the features of meningitis. So it's important to be able to consider both meningitis and subarachnoid hemorrhage high up in your index of differential diagnoses. The causes of subarachnoid hemorrhage. The main cause of a subarachnoid hemorrhage is an aneurysm, a ballooning of the arteries of the circle of Willis, if you remember your neuroanatomy well. That is the #1 cause of subarachnoid hemorrhage. The next one is an arteriovenous malformation. So an intracranial aneurysm causing this hemorrhage is often called a berryaneurysm, and classically it's associated with polycystic kidney disease. I've got no idea why there's that association, but it comes up in exams. So in the vignette, it might say they have a previous medical history of polycystic kidney disease and they have a sudden onset headache. You want to think, this is not just a subarachnoid hemorrhage, but it's caused by an aneurysm. You might think it's caused by a malformation in the blood vessel system, if in the vignette it says there's a history of seizures, but this is much less likely than an aneurysm. In terms of clinically approaching a subarachnoid hemorrhage, the most important investigation you need to do urgently is a non-contrast CT. That will tell you if there's a subarachnoid hemorrhage. And if doubtful, you can do a lumbar puncture. I don't think this is really done that much, but there's lumbar puncture shows xanthochromia, which is basically a yellowing of the CSF. So subarachnoid hemorrhages mainly caused by aneurysms. Investigation, most important is a CT, if not do an LP. In terms of the management of subarachnoid hemorrhage, it's mainly under the guise of neurosurgery. They do this sort of, they do surgery things, clipping, endovascular clipping for aneurysm. But in terms of long-term preventative measures, you put the patient on nimodipine, which is a calcium channel blocker, for 3 weeks after. Okay. All right, so those are the two main causes of secondary headache. We've gone through meningitis, we've gone through subarachnoid hemorrhage, and I hope you've started to think about the sort of questions you might want to ask. The next one is raised intracranial pressure, and this has many causes, but the way in which you pick up raised intracranial pressure is if the patient says that the headache is really bad in the morning, they've been having it as soon as they wake up, they've been vomiting as well. They feel as though the headache is worse when they're straining or they're coughing or they're bending over, or if they sneeze, they get the headache. And if they bend over or cough, their vision is also blurred a little bit. So those are the 4 sorts of questions you might want to ask if you're suspecting that this headache might be due to raised intracranial pressure. I'm going to show this. Can anyone tell me on the chat what this what this finding is? it might be wrong, but Oskistop says that TB is generally lymphocytes as well. Okay, I took it from Geeky Medics. Geeky Medics said it's neutrophil, it's polymorphs. It's more likely that it would be polymorphs because polymorphs tend to, because TB is a bacteria. Do you not do an LP if the GCS is reduced? In subarachnoid hemorrhage, I think the first thing you would do is a CT. That's more important. Okay, everyone has fallen into my trap. You've all said papilledema. You're all wrong. This is a totally normal retina. This just shows, yeah, fundoscopy is taught so badly at medical school. This is completely normal. Here's another picture. You've got your fovea, your macula around it. The optic disc is it's not blurry at all. The margins are very clear. But it raises an important point, and everyone knew that you have to look you have to do fundoscopy for raised intracranial pressure. So in an OSCE, if you ask these sorts of questions and they say, "Oh, my headache's worse in the morning, I'm vomiting, I have visual obscurations when I cough," at the end of the OSCE, you would say, "I would like to conclude this history taking by doing fundoscopy to look for papilledema." And papilledema, as many people said the normal image was, is optic disc swelling and blurring of the disc margins, and that's because of a raised pressure in the cranium. And here are some examples of papilledema. This is particularly, the one on the left is particularly aggressive papilledema. The one on the right is slightly more subtle, but can you see that there's a blurring of those margins? I think that's the main thing you've got to look for. If we look here, the margins are completely clear. It's really easy to tell to see that circle. Here it's a little bit more difficult. It's a little bit obscured, it's a little bit blurrier. This is papilledema. Like I said, CT is the most important thing for you to do, and the main cause of raised intracranial pressure that everyone thinks of is a mass, a tumor. That, of course, is one example, but there are also other causes of raised ICP. There can be a clot in the venous sinuses, and that is typically associated with stroke-like symptoms and seizures. It could be hydrocephalus, so a kind of imbalance in the pressures of the brain, or it could be focal edema, and it could be due to trauma. So it's always important to ask, has the patient suffered any trauma to their head or to their neck? Always a good question to ask. Okay, so what if the patient says they've got all these symptoms, you've asked all these symptoms, these questions, and you've done a CT, but there are no findings on the CT. They've got papilledema. You might want to consider a condition called idiopathic intracranial hypertension. And this often does come up on MCQs. And the main way you're able to tell that it's IAH is because of the risk factors. If it's a young woman who's overweight and has polycystic ovarian syndrome, or 2 out of the 3 really, you're more likely to think it could be IIH. In terms of the clinical semiology, they say that it's quite similar to the raised ICP picture: general throbbing in the morning and the last thing at night, relieved on standing, which is something peculiar to this condition, but they also have the papilledema and aggravation on straining. The main thing for this particular condition is that you know when to pick it up. In terms of the management, I don't think you need to know that much. It's generally self-limiting with weight gain, with weight reduction even, and there are a few other sort of management bits that it's unlikely to come up in exams. So in terms of intracranial pressure, taking a good history, looking to see if there's papilledema on fundoscopy, doing a CT scan, and also picking up these sorts of risk factors for other differential diagnosis is really important. So I hope that gives you a good overview of raised intracranial pressure as a cause of headaches. Okay, I've got a clinical vignette here. It's a patient who says, "I have a headache which has suddenly developed over the past few weeks. Normally it's around the front and the sides of my head. It's so bad that I find it difficult to comb my once youthful hair. And recently I found it difficult to eat. It's become a bit painful. Can anyone tell me in the chat what is causing this headache? Good, we've got a good range of differential diagnosis. GCA, trigeminal neuralgia, tension type headache. These are all very good things to suggest. But the most important thing is temporal arteritis, or giant cell arteritis. They're the same thing. This is a condition that you must suspect if the patient is above 50 years old. It tends to be more likely in women, but you need to consider it in both sexes. And the classic line they say is that combing my hair is painful. And it's an inflammatory condition. It's a inflammation of the temporal artery. And they have a headache, they have scalp tenderness, and they have jaw claudication, which means that they have pain in their jaw and the mouth, and they typically say it's really difficult to eat, it's quite painful. They might also have other systemic features like myalgia, malaise, and fever. And if the condition has progressed slightly more, they might have transient visual symptoms. So they might have some blurring in their vision, or they might even lose some of their vision. And importantly, they might have abnormal palpation of their temporal artery. So when you palpate the temporal artery, there might be absent pulses, or it might be even more throbbing. So this is a really important inflammatory condition that can cause secondary headaches. It tends to be a little bit more chronic, but it can come up within a day. And it's important for you to think about in a more elderly patient. The guidelines for temporal arteritis have very, very recently changed, just a couple of months ago. Before they said the ultrasound or biopsy, I don't think they said it was that necessary. Now they say, in order to confirm this diagnosis of GCA, you need to do either a temporal artery ultrasound or a temporal artery biopsy to look for skip lesions. This is the only way to confirm a diagnosis of giant cell arteritis. Now, I mentioned that patients with GCA get visual symptoms as well. And that's really important for you to elicit in your history. So when you're thinking about history taking, always ask about visual symptoms, blurring of vision, loss of vision. This is important because it means you change your management of temporal arteritis. And I think this is really the only time where you really, really need to know about dosages, especially in first year of clinical medicine. If the patient has visual symptoms, the treatment, which is prednisolone, a steroid, is 60 to 100 milligrams. It is higher if they have visual symptoms compared to if they don't have visual symptoms. If they have visual symptoms, it's 60 to 100. If they don't have visual symptoms, you give them 40 to 60 milligrams of prednisolone, oral prednisolone. Other important investigations, you might want to do some blood tests. The most important one is ESR, erythrocyte sedimentation rate. ESR is a way of measuring plasma viscosity. It is basically the alternative, an older version of CRP, and it is one of the few times where ESR is more important than CRP, as it can confirm diagnosis of GCA. Methylprednisolone can also be given, yeah. Someone mentioned trigeminal neuralgia. That's also an important differential diagnosis to keep at the back of your mind. The picture that I gave to you before wasn't exactly typical of trigeminal neuralgia. Normally they'll describe it on one side of their face, and it's like an electric shock pain. And it'll be to specific anatomical regions like the mandibular division of the trigeminal, so V3, or the maxillary division of the trigeminal, like V2. And it is normally on one side of the face, but if it is on both sides of the face, it might be something a little bit more serious, like some sort of brainstem pathology or demyelinating disease. And they tend to be older patients in trigeminal neuralgia. If it's younger, it might be the beginnings of MS or some sort of cerebellopontine tumor. Important risk factor for trigeminal neuralgia is hypertension. So in your past medical history about headaches, always ask about hypertension. And the management for trigeminal neuralgia is carbamazepine. It reduces the severity of attacks. It doesn't actually cure the condition itself. So I've gone through the sort of inflammatory conditions that can cause headaches. So that was giant cell arteritis, typically affects older people. They say combing my hair is difficult. It's difficult to eat food. Important diagnostic tests for you to do is temporal artery ultrasound or temporal artery biopsy and ESR. An important differential is your trigeminal neuralgia. Okay, that's everything you need to know about inflammatory causes of secondary headaches. The last secondary headache that I'm going to be talking about is acute angle closure glaucoma, and it's one that everyone misses out. It's an eye condition. And what it is the blockage of aqueous humor, of aqueous fluid flowing out of the eye. And as a result, in the anterior chamber of the eye, pressure builds up. And because the pressure builds up so much, you can get this loss of vision, pain around the eye, and it can go all the way around the head. This is a really important and one that shouldn't be ignored. So here's just a visual picture to show. There's a blocking of the drainage network and the trabecular meshwork, which means that you get a higher pressure in the eye, and that can cause visual loss. So the typical history in acute angle closure glaucoma is that they'll say they'll have a sudden severe pain within around the eye that spreads around to the head. If the patient describes headache around the eye, you need to ask about you need to either examine for a red eye or ask about a red eye to prove that you are thinking about this particular differential diagnosis in your OSCEs. You need to ask about blurred vision, and typically patients will say that they see halos around the light. That is your clue to think, I think this is acute angle closure glaucoma. They might also have nausea and vomiting. And when you do examine their eyes, you need to sort of palpate them because they tend to be tender and they also tend to be hard. And here's a photograph for you this is an example of quite severe glaucoma. And you'll see that the middle of the eye looks quite cloudy, but around the edges, it's quite, in the whites of the eye, it's red and bloodshot. And the kind of, the cause of this isn't massively known that well, but it's often thought that in situations of dim lighting where the pupils dilate, that can cause this sort of dysregulation of the trabecular meshwork, and that can cause the increased pressure in the anterior chamber, causing this particular presentation. So that's sort of the cause, that's one of the main causes of acute angle closure glaucoma, but there's also drug-induced glaucoma, which is important for you guys to know. So any drugs that can dilate the eyes, like mydriatics, tropicamide, or any anti-muscarinics can cause massive dilatation of the pupils and trigger this particular condition. And the ones that typically can cause this that you see in exams are nebulized ipratropium and tricyclics, and those two classes of drugs can trigger this particular condition. So in terms of the management of acute glaucoma, you need to refer to an ophthalmologist who will do a slit lamp examination. And there are a number of drugs that are used to combat this high pressure in the eye. Timolol, which is a beta blocker, acetazolamide, which is a carbonic anhydrase inhibitor, pilocarpine, which is a anti-muscarinic, and that lowers pressure in the eye. And that's a sort of acute management of glaucoma. You can prevent this by surgery, an iridotomy or iridectomy, messes with the iris, and that's sort of the more long-term prophylaxis for acute angle closure glaucoma. Okay, so that's everything you need to know about the secondary headaches. We've talked about infection, we've talked about meningitis, we've talked about bleeds, subarachnoid hemorrhages, we've talked about raised intracranial pressure and how to deal with that. We've talked about the inflammatory conditions, and we've talked about the eye conditions. And this is just a bit of a summary about things that you don't want to miss out when you're thinking a secondary headache. Always check the blood pressure, it's a good habit. Always do fundoscopy. If they're over 50 years old, palpate the temporal arteries, see if there's an abnormal pulsation. Always do a full neuro exam. It's very good practice to do so. So in your OSCEs, if you ever see a patient who has a headache, you would say in terms of the examinations you do, fundoscopy, palpate the temporal arteries, full neurological exam, cover all bases. And you'd like to check their GCS to see if there's any decreased consciousness, because that is a bad sign. Other things not to forget: fever and neck stiffness when we're talking about meningitis, scalp tenderness in GCA, any trauma in the head and the neck, painful red eye and dilated pupil for angle closure glaucoma, papilledema, and fevers if there's any infection or systemic illness. So those, again, always, keep these at the back of your mind, ask these sorts of questions, do these examinations. And also, lastly, the features of hypothyroidism. I'm not going to talk that much about hypothyroidism, but that can also cause headaches. And a really important point that I wanted to drive home is that it's very, very rare for strokes to cause headaches. When you have a hemorrhagic stroke, it's normally the neurological symptoms of weakness that are overshadow the headache. So if a patient comes in with a headache, stroke should really be on the bottom of your differential diagnosis list. Okay, that's everything about secondary headaches. I'm going to just check the chat if there are any questions. If a patient with epilepsy has trigeminal, will you change the epilepsy medication to just carbamazepine, or would you add it on? If the patient has, so carbam, I don't quite understand what you mean. Yeah, I don't quite understand. I don't really know about epilepsy and trigeminal neuralgia. That's quite a complex problem. What exactly is glaucoma? It's build-up of pressure in the anterior chamber of the eye. Okay, so let's do some SBAs because I've been talking a lot. A 59-year-old woman presents with a sudden severe headache. She complains of pain around the eye and she cannot stand the light. She has vomited since her headache. She describes it as the worst headache she's had so far. Neurological exam is normal. Here's the poll. What's the most appropriate investigation? Is it lumbar puncture, CT head, MRI, cerebellar angiography, or LFT? Okay, cool. Great. Vast majority of you got that correct. It's a CT head. So here, this is a little bit of an unusual, but the main thing that you're thinking of is a subarachnoid hemorrhage. And the key line is she describes it as the worst headache she's ever had by far. If you ever see that, you need to think subarachnoid hemorrhage, so do a CT head. Great, well done. Next one, long question. 34-year-old woman is admitted with a 2-day history of headache and malaise. She's vomited twice and has a recent sore throat. Her GP has been treating her with topical antifungal cream for vaginal thrush. On examination, she has moderate neck stiffness. CT appears normal, and here are the CSF findings. Let me just put the poll on. So the CSF shows high pressure, lymphocytic infiltration, glucose is normal. And the options for you are Guillain-Barré syndrome, tuberculous meningitis, fungal meningitis, viral meningitis, or Osler-Weber-Rondeau syndrome. Okay, cool. I'm going to end the poll there. Yep, majority of you got it correct. It's acute viral meningitis. So if you have a look at the CSF findings, it's lymphocytic infiltration and normal CSF glucose levels. Viruses don't like sugar. Bacteria and fungi like sugar. Viruses don't. Good, well done. Next one. A 60-year-old woman has a 5-month history of weakness getting out of her chair. She also has a right-sided temporal headache and complains that it's painful to brush her hair. Her doctor suspects polymyalgia rheumatica with temporal arteritis. Which blood test is important in supporting the diagnosis? One thing I didn't mention when we were talking about giant cell arteritis is that it's often in combination with PMR, which is another inflammatory condition that affects the shoulder girdle and pelvic girdle as well. You get weakness. Okay, most of you have voted. Good stuff. So this seemed to cause a bit of, seemed to be a little bit challenging. So the exam is, the answer is plasma viscosity. And it's a bit of a difficult question because I didn't necessarily put ESR. But the reason why CRP isn't as important in temporal arteritis is it's one of the few conditions where CRP isn't a good test of inflammation. The answer is ESI, erythrocyte sedimentation rate, which is a measure of plasma viscosity. So bit of a tricky one. But yeah, the answer is plasma viscosity. Okay. So those that's everything about secondary headaches. I hope that makes a modicum of sense to you. I'm just going to check the after the question, please explain what Osler-Weber-Rondi syndrome is. Osler-Weber-Rondi syndrome is a ridiculously rare condition. It's hereditary telangiectasia. So I don't know if you do gastro examinations, you look for telangiectasia, which are those little kind of spots you get in and around. You get it in like various rheumatological conditions. It can cause little blood spurts in various organs of the body. I would not worry about Osler-Weber-Rondi syndrome. It's extraordinarily rare. I put it in there just to mess with you guys. Okay, yeah, secondary headaches. That's everything done. I hope you've put in the corner of your paper what sort of questions you'd like to ask if you suspect secondary headaches. Here are my, here's a list of the sorts of questions you might want to ask. Red flag symptoms. So, you know, if they're over 50, you want to be a little bit more cautious. If they've got fever, neck stiffness, rash, nausea and vomiting. Have they described it as a sudden onset of the worst headache ever? Is it worse on coughing or sneezing or straining? Makes you think of raised ICP. Worse on waking? Are there visual symptoms? Do they have seizures? Are they confused? Do they have a red eye? Is there a weakness anywhere? All important questions, all important things you've got to keep at the back of your mind. Headache histories aren't easy. I've also put, are there other people in your house that have the headache? Can anyone think of a reason why you might want to ask that? It's a bit of a rogue. Yeah, someone's just put CO, which is, I presume they're saying carbon monoxide. Yeah, good, yeah. Carbon monoxide poisoning is also a cause of headache. So if other people in their house have got it, that's something you might want to ask as well. But again, it's a little bit rare. Okay, so we've gone through secondary headaches. Hope that makes sense. We're going to be talking about primary headaches now. Primary headaches tend to be a lot more common. They're the things that you tend to see in GP, but they're the chronic conditions which can really severely affect quality of life. Important to keep in mind. So the three types of primary headaches that I'm going to be talking about are tension type headaches, migraines, and cluster headaches. And like we did with secondary headaches, I'm going to keep these conditions in the corner so you have a good overview as to what conditions are coming up next. The main one you need to know about is migraine. So I'd keep an eye on the migraine section of this presentation. So tension type headaches. Tension type headaches is kind of unlikely to come up in MCQs. It's definitely unlikely to come up in OSCEs. It's the kind of really, really common headache that you've probably had probably during this this session. It's just that kind of like classic headache that goes around a band around your head. It's kind of this pressure going on your you feel on your head, and most of the time you just manage it with paracetamol. There doesn't tend to be any other associated symptoms. Sometimes you can get it after not particularly severe trauma, mild or moderate trauma. It's one of those things that you just, take some paracetamol, you'll be fine. So that's the first type. Wouldn't worry too much about it. The next one, really important one, is migraine. This is a chronic condition that affects a lot of people. And the important symptoms of migraine are, one, headache, of course, this sort of throbbing unilateral headache, typically. Photophobia or phonophobia. So that means that they tend to avoid the light and they tend to avoid loud noises. And also there might be associated nausea and vomiting. And a really classic line that migraine patients will say is that I'd like to lie down in a dark, quiet room, and that's their way of dealing with it. So if you see that in any of your clinical vignettes, or if the patient says it in OSCE, think migraine. And also one thing I haven't put down in the PowerPoint presentation is obviously in your Socrates you ask how long this has been going on for. The secondary headaches tend to be they don't tend to be chronic problems that you've had for a long time. Primary headaches are. So it's likely the patient has been dealing with this for a long period of time in their life. When you suspect a migraine, the important distinction you need to make is it a migraine with aura or a migraine without aura? I'm going to talk a little bit about aura. Aura tends to, it's about 20 minutes before they get the headache. And typically it's visual symptoms they get. So they might describe shimmering in their peripheral central vision. They might get these sort of zigzag lines, that's known as tachopsia. They might get in their peripheral vision these sort of patchy losses, that's known as scotoma, or they might get tunnel vision where they're not able to see any of the peripheral vision, they only see the center of their visual field. So if they get those sorts of symptoms before their headaches, think migraine with aura. Slightly less common are focal neurological signs as aura before they get the migrainous headache. So they might get tingling, they might get dysphasia, and they might also get these sorts of motor symptoms like motor weakness. They might get a weakness around one side. This is slightly rarer. It's not something that many migraine with aura patients get, but it's important because if you ever see a patient with stroke, and a consultant asks you, what are your differential diagnoses, and you can't think of anything, migraine with aura is a good thing to say, because that can cause weaknesses, focal neurological weaknesses. And another one, which is again pretty rare pretty rare in its prevalence, is acephalous migrainous aura. So what that means is that they have the aura, but they don't have the migrainous headache. So all of these symptoms, the visual symptoms, the focal neurological symptoms, they have, but they don't actually get the headache. And it tends to be the sort of typical age range is over 50, and it tends to be men who get that. So another one that you might want to add to your differential diagnoses when you see a patient with stroke. So yeah, we've talked about the symptoms of migraine, and we've talked about auras. Migraine without auras is just a migraine without aura. You have the symptoms of the unilateral throbbing head pain, nausea and vomiting, and they might want to lie down in a dark, quiet room because they want to keep away from the light. They want to keep away from loud noises. Another one I didn't mention actually in the core symptoms, it can be motion sensitive, so they don't want to walk around that much. Great, so that's everything you need to know about migraines, the most important cause of primary headaches. No, it's not. I'm just going to talk about management. In terms of management of migraine, you need to think about the acute management of when they have the migraine, and also the preventative measures you need to put in place to prevent future migraines. So acutely, advise your patient if you have diagnosed them with migraine to avoid any triggers. This might be particular foods or lack of sleep, the sort of thing you've got to gauge from history taking. You also need to prescribe an analgesic and an antiemetic. Analgesic because obviously it's painful, and also to stop them from vomiting, which is one of the key features of migraine. And that can be, so analgesic can be aspirin, paracetamol, or NSAID. However, a really important thing that you should do in your OSCEs, which will give you some extra points, is advise them not to take too much of their analgesia, because there is, you can get medication overuse headaches. So if you take too much, too many painkillers, that can also precipitate a headache as well. Wouldn't advise them to take too much. The second line for migraines, so they've avoided the triggers, they've taken the analgesic, they've taken an antiemetic. If that doesn't work, the next line are triptans. For example, subitriptan is a triptan, and you give that normally orally, but if they are vomiting at the time, it can be given subcut as well. And a contraindication of triptans are vascular disease, so never give it in a patient who has peripheral vascular disease, for example. And again, sort of like little OSCE tips that might get you those extra ticks on the mark sheet is these acute medications should really be given when the pain is mild, and only take triptans before the headache, not before the aura. So if you think you have an aura coming, those visual symptoms, don't take it then. Take it once you've had the visual symptoms for a good sort of 15-20 minutes, or if you know how long your aura is, take it during your aura, just before the headache starts along, because apparently that's the best, that's when it's most therapeutically effective. So that's the acute management of migraine. The preventative measures of migraine. The first line is propranolol, which is a beta blocker, slow release, 80 to 160 milligrams. You can also give topiramate, but this is less likely to be advised because it can reduce the efficacy of the oral contraceptive pill. So avoid in women of a childbearing age. Tend to just go for propranolol in general, and amitriptyline, which is a antidepressant. No, it's a one of those peripheral for neuropathic pain. It can also be used for migraines. An important patient safety bit to note: if a patient has a migraine with aura, never prescribe the combined oral contraceptive pill because there's a risk of stroke. So that occasionally does come up in MCQs, so an important fact for you to know. Okay, so we've gone through tension type headaches and we've gone through migraines. The last type of headache we're going to be talking about are cluster headaches. Cluster headaches, think of them as the opposite of migraines. So whereas people with migraines, they want to lie down in a dark room, they want to get away from everyone. Cluster headaches make people aggressive and angry. They get restless, they run around loads. And the symptoms of these type of headaches is that it tends to be unilateral and quite severe, but they also get autonomic symptoms. So they might get redness around their eye might start tearing up, they'll get nasal congestion, and you'll also get these other sympathogmimetic features like ptosis and meiosis. And I think the most important one is, ask how do you react to these headaches? What do you do to make them feel better, or just generally how do you react? If they say I get really restless and I get quite angry and I start sort of tearing up on one side, think cluster headaches. And they're called cluster headaches because they occur in clusters during their year. So they might have it several days in a row, and then they will have a period where it's fine, and then several days in a row. And they tend to last around 15 minutes to an hour. And the management for cluster headaches is high flow oxygen and subcut sumatriptan. So it's similar to the acute management of migraines. What antiemetic do you usually give? Metoclopramide. Metoclopramide, I'm sure, will be fine. Always check the BNF though. What do you give a patient with IHD/PVD in an acute migraine if triptans are contraindicated? That's a good question. So follow senior advice, I guess. I don't know about if it's contraindicated, what are the other options for acute management. For migraines, are triptans used alongside normal analgesia? Yeah, on top of the normal analgesia, yeah. Good, okay. So we've gone through primary headaches and we've gone through secondary headaches. We're going to go do some SBAs. I think I've got 3 here for you to do. So a 32-year-old man attends his doctor because of severe headaches in the morning. He also complains of having visual problems. On examination, the patient appears to have bitemporal hemianopia. Oh, damn it. Ah, no. Ignore that. What if it was a test? Yeah, okay, fine. I'm just going to end the poll. Yeah, you got it right. It was optic chiasm because I accidentally pressed the button twice. So this is just kind of a bit of revision from neuroanatomy. This is a case of, it's a severe headache in the morning. He's got visual problems. So you're thinking of raised ICP. Bitemporal hemianopia classically is associated with a pituitary tumor. And what that does is that it impinges on the optic chiasm, causing your peripheral vision to be lost. Okay. That's fine. Next question. An elderly woman has a severe headache, nausea, vomiting, and a painful red eye. She has reduced visual acuity in this eye specifically. On examination, her eye is hard and there is a marked pericorneal reddening. Her corneal reflexes are hazy. Tonometry shows raised intraocular pressure. She started some new medication. Which medication will account for this acute presentation? Give you some time for this. Sorry if I've been going quite quickly in this one. There's a lot to get through and I didn't want to run over. Okay, most of you have voted. And most of you got the question correct. So the correct example, the correct answer is ipotropium nebulizer. So you might have slightly got a bit confused with this question. So the diagnosis here is acute angle closure glaucoma. These other drugs, azetazolamide, azetazolamide, timolol, pilocarpine, these are all treatments for acute angle closure glaucoma. So they reduce the pressure in the eye. Ipotropium bromide is an antimuscarinic and it increases the pressure. So it can cause glaucoma. Okay, next question. 20-year-old woman has recently started developing an intermittent right-sided headache associated with vomiting. She only gets them once a month. She tends to lie in a dark room, which says it helps. The only medication she takes is the oral contraceptive pill. What's the diagnosis? Okay, most of you voted. Most of you are correct. This is a really classic description of migraine, one-sided headache associated with vomiting, tends to lie in a dark room, which says it helps. There's no risk factors for idiopathic intracranial hypertension like obesity or polycystic ovarian syndrome, and it's not really a typical tension type headache picture. Last SBA. Thanks for keeping with me. Previously healthy 30-year-old woman complains of a headache. The headache is described as unilateral, throbbing, and lasts all day. She tends to avoid the light and loud noises. Neurological examination is unremarkable. She takes the OCP. Which medication is most suitable at reducing the frequency of her headaches? Okay, most of you voted. Okay, so there was a bit of a split between sumatriptan and propranolol, and the correct answer is actually propranolol. So the question is not what would you give to acutely treat her migraine, which is the diagnosis, but what is used as a preventative measure to reduce the frequency of her attacks. And when I talked about the suppression of future migraines, the key drug to remember is propranolol. Some of you put topiramate, but she is of a childbearing age, and it might reduce the efficacy of her oral contraceptive pill. So the correct answer is propranolol. Right, well done. That's everything that I really want to say. I think I'm just going to summarize as to what I think I wanted you to take away is it's all in the history. For headaches, there are loads of questions that you need to ask, and I hope you got a good idea as to the sorts of associated symptoms you might want to ask for. And you can use this to differentiate the two types of headaches, primary and secondary. Primary headaches being the more chronic stuff, secondary headaches being the more dangerous, high mortality stuff that you really don't want to miss out on. Thank you very much for coming to this Becoming a Doctor tutorial. I hope it helped. Please put in some feedback. Would be greatly appreciated. Great, thank you very much. You can finish. Oh, there were questions. Oops. Okay. I'm still alive, so I can answer a few of the questions. Can't see the question. Oh, here we go, Q&A. Do we give dexamethasone for all bacterial meningitis prior to the first antibiotic? You don't need to give dexamethasone for bacterial meningitis. Do not do an LP. We already answered that in the chat. Are the autonomic symptoms unilateral? Presumably this was for cluster headaches. No, I don't think they are. How do you usually treat intracranial idiopathic intracranial hypertension if topiramate is contraindicated in women of a childbearing age? You would not use topiramate to treat idiopathic intracranial hypertension. The management for IIH is primarily conservative, and there are a few other drugs that can be used, like acetazolamide, I think. I wouldn't worry too much about the management of IAH. The question that always comes up is mainly diagnosis. Good. I think that's everything. Any idea if these lectures are going to continue next week? I don't know. Hiran, you might be able to answer that question. I think they are. Yes, they are. I'm not doing any, which might be a blessing or a burden. Who knows? Cool. I'm ready to end this.